Which of the following statements regarding the use of ketamine is false? Benzodiazepine coadministration has not been shown to reduce the incidence of emergence phenomenon in children. B. Despite increased secretions, airway reflexes are generally well maintained. C. Hypotension is common. D. Profound analgesic and sedative effects occur with minimal respiratory depression. E. Repeat doses are well tolerated in longer procedures. The answer is C. Hypotension is common. Ketamine increases the release of catecholamines on administration and supports blood pressure well. It also decreases smooth muscle tone in the bronchial tree and may have a benefit in patients with reactive airways disease. Several studies have failed to show benefit with the concurrent administration of low to moderate dosages of benzodiazepines in preventing emergence phenomenon in children. These studies have shown a slightly increased risk of side effects. Their routine use is discouraged and should be reserved for the actual treatment of severe emergency phenomenon. Question 2. Which of the following statements regarding the use of Propofol is true? Propofol has a long duration of action and provides significant analgesia. B. Propofol has significant antiemetic properties. C. Propofol is cerebroprotective. D. Propofol is well tolerated in volume-depleted patients. E. The use of ketofol, ketamine in combination with Propofol, is clinically superior to the use of Propofol alone. The answer is B. Propofol has significant antiemetic properties. Propofol is an ultra-short-acting, sedative hypnotic, cerebroprotective agent with no analgesic but profound antiemetic properties. Its adverse effects include dose-dependent respiratory depression, apnea, hypotension, and pain on injection. Preload-dependent patients are particularly susceptible to hypotension. Its combined use with ketamine is common. The two agents are thought to have synergistic effects that balance each other's deficits. Their combined use has been shown to improve provider satisfaction, sedation quality, and decrease emesis, but has not been shown to be clinically superior to either agent used alone in regard to respiratory depression, airway complications, or improved recovery times. Question 3. Which of the following statements is true regarding the need for fasting before procedural sedation? A 6-hour period of fasting is required after the ingestion of liquids or solids before procedural sedation. B. Preprocedural fasting is required in all cases. C. The recommendation for preprocedural fasting is based on controlled trials involving patients undergoing procedural sedation. D. The risk of vomiting and loss of the airway protective reflexes is an extremely rare occurrence during procedural sedation. E. There is an increased risk of aspiration during procedural sedation after a liquid or solid meal. The answer is D. The risk of vomiting and loss of the airway protective reflexes is an extremely rare occurrence during procedural sedation. It recommends a period of 2 hours after ingestion of clear liquids, 4 hours after ingestion of breast milk, and 6 hours after the ingestion of other liquids or solids before the performance of procedural sedation. This recommendation is based on expert consensus and has been extrapolated from data on patients receiving general anesthesia and manipulation of the airway during intubation and extubation. There are no published studies showing an increased risk of aspiration after a liquid or solid meal nor benefits of fasting before procedural sedation. Large studies have shown no clinically significant differences with airway complications, emesis, or other adverse effects among groups of patients stratified by their preprocedural fasting status. The risks of procedural sedation should be balanced against the risks of delaying a time-sensitive procedure. Question 4. A 27-year-old firefighter presents with a headache, chest pain, and severe shortness of breath after working at the scene of a house fire. The physical examination is remarkable for a blood pressure of 155 by 90 mmHg, heart rate of 110 beats min, respiratory rate of 28 breaths min, oxygen, O2 saturation of 98% on room air, and clear lungs. The chest radiograph is unremarkable. Which of the following may be responsible for a normal O saturation despite such respiratory stress? Carboxyhemoglobin. B. Cyanide. C. Melanin. D. Methemoglobin. E. Methylene blue. The answer is A. Carboxyhemoglobin. Pulse oximetry is based on differences in the optical transmission spectrum of oxygenated and deoxygenated hemoglobin. Pulse oximeters measure the pulse variation in red and infrared light transmitted through a tissue bed. Data averaged over several arterial pulse cycles are then presented as saturation. Carboxyhemoglobin contributes to light absorption and causes errors in oximetry readings. The pulse oximeter senses carboxyhemoglobin as though it were mostly oxyhemoglobin and provides a falsely high reading.